Thank you, Dr. O'Donnell. It's an honor to be able to talk to you all today. Can you hear me okay? So I'm well known as having a hard time staying on time in my clinic because I feel like my patients become my friends after a while, and I always look forward to seeing them, and then it's hard to stay on time in clinic. And to look out and see you all in this audience is it's just so heartwarming to see that we can get a chance to talk to you all as a group, and so thank you for being here. So I've been tasked with the bronchiectasis overview, and I suspect that you guys are pretty sophisticated players here, so I hope I'm going to match your level of expectation, but that's what questions are for. So, I think a lot of you know this, that bronchiectasis is increasing. So even if it wasn't increasing, it's still a very important disease, but the fact that it's increasing has implications on impact of healthcare, impact of your personal lives, your people who you live with and are caretakers for, your grandchildren who you help take care of. The fact that this is affecting more and more people has implications beyond just what those words would suggest they mean. And so Dr. Seitz is a researcher and epidemiologist at the NIH, and she has identified that the bronchiectasis has steadily increased over years. Of course, this isn't, hot off the press, but we probably think it is still increasing since 2007, and it seems as though it's increasing more in women than in men at this time. So we know from Medicare data, looking at patients who are generally, for the most part, over 65, that bronchiectasis increases as people age, and it peaks at ages around 75 to 80. But that's not to underestimate how important the group is, the younger years, in the ages 80 to 34 that I have here. Perhaps we may be able to find treatments for these patients and affect their outcome. And let those coughs rip, we don't want you to keep those coughs down. It's important to cough, so go ahead. I'll just talk louder, okay? All right, we also have found through also the work from the epidemiologists at the NIH that bronchiectasis prevalence varies throughout the country. This may be for lots of different reasons. It may be environment, and you'll hear about environment later this afternoon. It may be the threshold for doctors to look for it. It may be that these patients have been misdiagnosed as asthma and they're not been diagnosed yet. I don't know actually why the prevalence is so varied, but nevertheless it is. And so you can look on there and find your state, if you're not from this one, to see how common your disease is. So how do you diagnose bronchiectasis? I suspect that many of you have had a diagnosis other than bronchiectasis for the first 15 years. Perhaps it was asthma. Perhaps even someone said something as frustrating as anxiety for your cough. We've heard all these unfortunate stories. But I want to tell you how we go about diagnosing it. So first of all, you know the symptoms. So I didn't make a slide for symptoms, but you know that you've had a cough that occurs daily. This is interrupted sometimes by intermittent periods of fatigue that are so overwhelming you have to stop your schedule to take care of that fatigue. You may have intermittent fevers. You may have chest discomfort. Your cough may be productive of purulent sputum. It sometimes may be productive of blood, and that blood can come at very unexpected and inconvenient times. So these symptoms are important in the diagnosis. They are necessary to make the diagnosis, but the specific diagnosis is made by the CT scan. So I'm going to back up a little bit before I go through the CT scan and remind you that, as you know, your trachea bifurcates inside your chest, and from there it breaks off into all the other airways, and those airways need to taper as they move out to the periphery of your lungs. Just like a tree, the branches taper as they go out to the periphery. In bronchiectasis, that tapering doesn't occur naturally. Now, as a reminder, every airway that travels out to the periphery of your lung is accompanied by a vessel. And we use that to compare the size of the airway. If the airway is bigger than its accompanying vessel, then that is consistent with diagnosis of bronchiectasis. And so I'm going to get to a more specific slide on that in a minute. But I just want to remind you that your disease occurs in the airways. Now, I've just, pardon me, I think I have a pointer here. Oops. Okay. If you could look at the right side of the slide and see the alveoli, those are the terminal lung units. Your disease is not happening there in the gas exchange terminal units. If you have friends that have idiopathic pulmonary fibrosis, their disease is happening way out in the periphery and the tissue between the alveoli. Your disease is happening more in the bronchioles and in the more centrally located airways. So if I convert this sort of cartoon of your lungs to a normal CT scan, that's sort of what a sense of the CT scan is looking at. And many of you have your doctors go through your CT scan, but just for those of you who may not have had this, I thought it might be fun to go through the CT scan. So everything that's air on a CT scan is black. So you can see the trachea down the center of the chest is black, because it's mostly air. And the lungs also are mostly air. And those airways that are traveling through to the periphery of the lungs, accompanied by a blood vessel, those show up as like little delicate structures of white that go over to the periphery. So this is sort of the features of a CT scan and the way the chest looks on the CT scan. That big glob in the center is the heart, but we don't care about the heart today because all we're talking about is bronchiectasis, because that's the most important disease today. I want to now explain that when we see you in clinic, we flip the CT scan and we look at it this way. So we have a person there is lying on that CT scan bed the way you've done when you go to have your CT scan, and we're going to slice your chest like it's a loaf of bread. And so now we're just looking at this cut of your chest, and it's called an axial view. And as you can see, this is a normal view, that those airways just look like this delicate architecture of blood vessels and airways as they taper through. And you can see how you can barely really see the airways as they go out to the periphery. In the case of bronchiectasis, these airways don't taper. And so where I've identified B there is an example of an airway that is kind of stuck open wide like a cylinder as it travels out to the periphery. When you see an airway like I've noted A, where it kind of ends in a cyst, that's sometimes what we call cystic bronchiectasis, where the airway kind of ends in this pouch. Very likely to trap sputum there. And where I've identified C, that is the airway with its accompanying vessel, and that's sort of the that's like the very diagnostic feature of bronchiectasis. That airway with that little bump next to it, that little bump is the vessel, that is called a signet ring sign. And as you can see, that airway is much bigger than its accompanying vessel. Another example of bronchiectasis, and as I'm showing here, you can see that bronchiectasis in some people is more focal in one area of their lungs than the others. And that might be in your case too, that you have more focal areas of bronchiectasis than others. Again, this is a more mild to moderate case of bronchiectasis where it is more focal in manifestation, and then bronchiectasis can get very, very severe. And you know what, though? It's important to remember that whether your disease is mild or severe, you still have largely the same symptoms. You still have a productive cough every day. And so you don't get a medal for having worse disease, worse radiographic manifestations. We respect the mild disease as well because it can still cause just as significant manifestations. Another example of very severe bronchiectasis, and I'm showing these severe examples so that you can kind of just see a very extreme example so you really get that widened airway, how abnormal that is. And I'm going to back up again to this normal here. Remember this normal view where the airways are so delicate, and here in bronchiectasis they're so wide. Now, many of you might have mycobacteria disease, Mycobacterium avium, Mycobacterium abscessus, and there's a very classic feature that goes along with mycobacterium disease, and it's called tree in bud manifestations, and it's affecting the airways way out to the periphery, and they have this feature that looks like tree in bud. And it's actually the radiologists put that on their report. So in the periphery of that axial view of the CT scan, you can see evidence of tree in bud disease. So this is, again, I've been given this slide from the University of North Carolina, where they do really impressive video microscopy of cilia. So you may know about cilia. Those are the hairs that live inside your lungs, and they move sputum up and out. And so this is an example of, oh, I might need adult supervision on, is it oh, yay, I don't see it here. That's fantastic. Okay, so these cilia, I mean, even when you're just sitting there, they're moving like crazy, moving the sputum forward, and that happens in a normal person where the sputum is moved out of your lungs without even trying. It's just beautiful anatomy. The fact that this exists is just a miracle, but the reality is that your cilia aren't doing that probably right now, because the sputum that you make is heavy. It has inflammatory proteins in it. It's often infected with bacteria, and that makes it thick and heavy and sticky. And so your poor cilia is trying to lift this stuff, and it's not happening, and that's frustrating for you. So that's another more microscopic view of what is going wrong in bronchiectasis. So this is from a publication that Dr. Greg Tino and I did for our American Journal of Respiratory and Critical Care Medicine. And it's like this overview of how we approach bronchiectasis. And it's a little bit of a busy slide, so we're going to go through it in detail. But it's generally the whole picture in sort of one slide of how we approach our patients with bronchiectasis. The first thing that's very important is that we hope that there's a treatable cause. That is a big work in progress these days. There aren't very many treatable causes of bronchiectasis, and unfortunately, even if there is a treatable cause, we can't really reverse bronchiectasis at this time. So while it's part of the workup that we do, we look for causes like immunodeficiency, alpha-1 antitrypsin disease. Unfortunately, we're still coming up with a lot of cases that we don't know why you got that. But please hang in there with us, because there are some researchers who are working really hard to figure this out. So if you have to look at sort of the pie chart of bronchiectasis, there are some treatable causes. Immune globulin deficiency, typically diagnosed when people are younger, but that's replaced with immune globulin. There's an association with autoimmune disease, Sjogren's disease, rheumatoid arthritis, and then there's allergic bronchopulmonary ABPA, which we abbreviate that as ABPA. Aspiration can lead to bronchiectasis when severe. Alpha-1 antitrypsin disease is another cause. But you can see these are sort of small pieces of the pie. Primary ciliary dyskinesia. And then there's these sort of miscellaneous causes, which we hope will be more elucidated as we move forward. There's a big group of patients who had a bad pneumonia at some point in their life and then have developed bronchiectasis in that region. I think most of us who really are invested in this feel like we admit that that's somewhat of a cop-out on our part, because not everybody gets bronchiectasis after pneumonia, and so we hope one day we'll be able to figure out why some people get bronchiectasis in areas of pneumonia versus others. And then there's this gigantic, huge, frustrating piece of the pie that's idiopathic, and we hope that certainly that changes over time. The NIH is doing some very provocative research in gene variants, which may suggest why some people are more likely to get non-tuberculous mycobacteria. So it's a reminder that it's very important to link in to people who specialize in this so that as we develop more studies, we can have patients to study genes, to study blood, to study inflammatory markers. And as you know, there's a vicious cycle that kind of revs the bronchiectasis story. So there's we're not really sure where one person comes into this cycle and other people come in perhaps at different areas, but there's airway destruction and distortion. That's the bronchiectasis. Then that leads to this abnormal mucus clearance. Those big, wide airways, they don't get rid of mucus as well as the normal tapered airways. And then that mucus sitting there is a perfect environment for bacteria to colonize. And then because you have bacteria there, you have all these neutrophils that come in and want to, attack that bacteria, but then those neutrophils in themselves are causing more damage because they're releasing enzymes and they're causing more sputum. So there's this vicious cycle that we can't get out of, and we've tried to treat our patients from all aspects of this, and I think you'll hear more about treatment later. So the next part of this is that, the upper layer of what everybody should be having is sputum cultures from their doctor so that we can know what kind of organisms you're growing and initiating airway clearance so that you can get rid of some of that cough that's causing you problems throughout the rest of the day. So you're going to have a lecture on airway clearance later, so this is just a brief sort of image of what airway clearance involves. A nebulized agent, a nebulizer, and another device to help move those secretions. And along the lines of, devices to help move the secretions, there's a lot of options for you, and I know that Leanne Daniels is going to talk more about this in just a minute. Nebulized agents for airway clearance. I've admitted in the past that I have a preference for hypertonic saline. There are other agents that are used. Acetylcysteine, which is often hard to get, but some people prefer that. Albuterol, mannitol is used in Europe, and Dr. Ann O'Donnell has shown us that drugs that work in cystic fibrosis, like DNase, don't work as well in bronchiectasis, non-CF bronchiectasis. Again, I've mentioned that I'm very pro hypertonic saline, and that's because there is some data for hypertonic saline in people like you who have bronchiectasis, and that study has shown that patients were able to reduce some of their bacterial loads by using hypertonic saline over long periods of time. So that's important. If you tolerate hypertonic saline, it can help improve your bacterial loads. And then considering other aspects of bronchiectasis care, once you give your doctor your sputum culture and you get the result, there's many, many options for what to do with those. And again, this is just sort of to put it into context of the rest of your management, because you will hear lectures on what to do with these organisms. But I did want to say one note about Pseudomonas, and I know Dr. Greg Tino is going to talk to you about that, but Pseudomonas is one of our more formidable players. Many people have this bacteria. It tends to be a little bit more difficult to treat, and often it's about lowering the Pseudomonas burden. And what does that kind of show up as when you give your sputum culture? It's stained with some stains when you provide the sputum to the lab, and they look at the slide in the lab, and based on how that bacteria appear, they can tell you they think it's probably Pseudomonas, and then they plate it and grow it, and then they look at sensitivities of that bacteria. We think we have data to show that it's associated with a little bit more decline in lung function. So we all lose lung function, okay? We're all doing it right now. But people who have Pseudomonas probably lose a little bit more lung function over time because of the Pseudomonas. And that's why we're very serious about treating this bacteria and trying to lower the levels. I think Dr. Tino will cover this, but there's this very important original study that looked at what happens when patients get antibiotics for their bacteria. And this is sort of this study was a little bit of the Bible for us, that we think of this as we're treating our patients. What this study showed was several important things. Patients with bacterial loads that are higher have higher systemic inflammation, and that's important because that inflammation is what's making you tired. Stable patients who are treated, that's stable patients, people who feel well, who are treated with antibiotics, then reduce the inflammatory markers. So it's not just that the bacteria comes down, probably the inflammatory markers come down, and it's better for you to have a lower inflammatory load. And then the radiographic severity correlates with airway inflammation, and more bacteria causes more exacerbations. And nebulized antibiotics, in this particular study, it was nebulized gentamicin, does reduce inflammation compared to when using just regular saline, like a placebo. So this was a very important study in our field, and it sort of set the environment to validate and warrant the use of antibiotics. I was tasked with talking about a little bit of non-tuberculous. How am I doing on time? I have a little bit of time. So I mentioned briefly that when you provide a sputum sample, it goes to the lab, they look at it on a smear, and based on the appearances and the stains that the lab puts on this sputum, they can kind of tell what it is. And so with non-tuberculous mycobacteria, they do an acid-fast stain, and it just refers to the series of stains that they use and how the bacteria either keep the stain or get rid of the stain when they're rinsed. And so non-tuberculous mycobacteria is considered an acid-fast stain, and how many of these little guys they see in your sputum, they quantify it, and they'll say it's either, smear negative, 1+, 2+, 3+, or 4+, and that refers to how much the load of your bacteria is on your sputum that day. And for the most part, and this is a moving target, there's so many different species of this bacteria right now, but for the most part, the most common ones are Mycobacterium avium complex, and even that can get a little bit more complex, but no pun intended there. But and Mycobacterium abscessus are the kind of the more common non-tuberculous mycobacteria. Again, I know that you are all sophisticated players and you have learned a lot probably. I hope that what I've said wasn't too obvious for you. So I wanted to try to tell you something that you maybe didn't already know. When you submit your sputum sample to the lab, and it takes like 6 weeks, I kind of just wanted to give you an idea of what the heck is happening for those many weeks while you're waiting. First of all, I think it's important to know that when you give that sputum and you're looking for non-tuberculous mycobacterium, the lab has to scrub it down and get rid of all these other bacteria in order to identify the non-tuberculous mycobacteria. And that's why you have to give them so much. You can't just give a tiny little sputum sample and get a non-tuberculous mycobacteria, because they have to scrub it down with detergents to get rid of the H. influenzae and the Pseudomonas. So that's kind of cool, when you think about it, that this bacteria is resistant to all these detergents. And then after they do that, they put it on the smear, which is what I showed you, and then they take the stuff and they put it in 2 different types of culture plates. So they put it on these slants, which is called the LJ slant, and that's the solid medium. And then they also put it in this mycobacterial growth indicator tube, and that's where it's a broth culture. What's cool is that if you go down to the lab, first of all, it's fun because it smells really funny down there, but a really good microbiologist, an AFB microbiologist, can look at the cultures and she can tell you, this looks like TB, or this looks like Mycobacterium avium, this looks like abscessus. So it's kind of like a little bit of a museum trip. So those take a little longer, those solid mediums, so they do both. And then this mycobacterial growth indicator tube, which is called a midget, that's the one where typically it grows a little faster, and the lab will call you and say, yeah, we've got growth. Your patient has an AFB positive smear. And then from there, they scrape off the organism, and then they send it to all sorts of other places to figure out whether it's Mycobacterium abscessus or Mycobacterium colonae or Mycobacterium avium. So there's all this work going on that takes weeks to figure out. And this is what we have at University of Chicago, and it's this complicated, very expensive system where your sputum sample, ultimately grows this bacteria, and this bacteria goes through these complex steps where finally that's how later on you find what actual bacteria you have. And so it's not that we've forgotten about you when you don't get an answer right away about your sputum, but there's a lot of stuff that's going on in the background. And so this is an example of what a Maldi-Toff would spit out and tell us finally what kind of organism you have. Okay, I'm just going to briefly say exacerbations are, we recognize that this is probably the worst part of your life. What I think the worst part about exacerbations is this graph shows, and this was a study that came from patient diaries. The blue solid line in the middle, where at point 0, treatment day, is when a patient gets an antibiotic. And so this graph shows that some people have symptoms of exacerbations 34 days after they get an antibiotic. And we recognize that that's really, really awful for you. If you have a full-time job, that means you're taking days off of work, you're feeling sick. If you're taking care of your daughter's children, then you can't make it to help out with that, and that has implications for your daughter. And you feel crummy, and you're not sure when you're going to feel better. And we have tried collectively to figure out how to reduce these exacerbation frequency, and that's our priority. So know that you're not alone, and if this room is any indication of that, and that we care about those exacerbations. So that is a research priority now and moving forward. And so I hope that's been a little bit of an overview for you. Thank you so much for listening.
Thank you, PJ. Are there any questions for Dr. McShane? We do have microphones, but shout it out and I'll repeat it.
I noticed missing from the list of medications used to treat an exacerbation was tobramycin.
So you're absolutely right. I actually didn't put an all-inclusive list there. Tobramycin, colistin, aztreonam, there are so many. The one successful study of inhaled antibiotics in bronchiectasis is gentamicin. Unfortunately, the drug companies who have invested their blood, sweat, and tears into this disease, we have not yet been able to achieve a perfect signal for those other drugs. But we do use those other drugs. You're absolutely right.
And is there, well, obviously the answer is yes, but when I nebulized tobramycin, I felt so much worse. And I don't know if that's...
Do you want to...
That's because it was doing its job and leaving scar tissue? Or, I mean, I couldn't live with it.
So actually, Dr. O'Donnell was one of the researchers who studied that tobramycin isn't as well tolerated in bronchiectasis patients as it is in CF patients.
Dr. Tino is going to discuss that these issues a little bit later. So.
About hypersaline, I kind of make my own. Is that less effective? I just use the ratio with organic sea salt and distilled water. Is that?
Ooh, it's a very good question. I have had patients who've done this. Whether or not distilled water does end up containing mycobacteria is, I can't say for certain. It's not supposed to. I think it opens yourself up to potential contamination. Hypertonic saline, I tell, you may just enjoy making your own, but I want everybody to know that you can go to www.goodrx.com and list hypertonic saline 7%. You have to put in 7% sodium chloride, and you can get a coupon for that, and then it'll work out to like $18 for $60 for the month, or I've even seen like $20 for a 3-month supply. Because it should be pretty cheap and easy to obtain, and then you don't have to do that work.